everybody, or good afternoon if you're on the East Coast, or like our ASL interpreter, many hours earlier than the Central Time. So appreciate everybody being here this morning or this afternoon. I am Michael Munson, and you are hopefully here in the right place for Dismantling the Gates Informed Consent Models of Care. If we can just start with a moment to just reflect on where you are in this world, where you're sitting, where you're standing, the land that you're on, and take a moment to, whatever your belief set is, to acknowledge the land, to acknowledge the ancestors that lived on this land before you, and those that will come after you. Thank you. So today we're going to go through a few things. A lot of it has ended up being kind of historical to frame what has been, and then moving into what is more in the now. So we're going to talk about the history of models of care. What is informed consent, which I think most of us know, but just we'll place that in the framework of doing trans-related care. What are some of the impacts on therapeutic relationships? How do we make sure that harm reduction is a part of the work that we're doing with clients? What are some of the implications in today's world where things are not the most pleasant for trans folks or for providers who work with trans folks? And then we'll end with some actions, some things that you all can do right now moving forward. I want to remind folks to take care of yourself. You'll see this slide on every single webinar that you attend that's by Forge. We encourage you to interact, so lean in if that feels comfortable to you, participate if you want to, and don't participate if you don't want to. We'll have just a few options today to have some interaction. Again, I'm Michael Munson, and to give you a little bit of a visual description, today I have on a lavender shirt. I had on a scarf before, but not anymore because it's hot. Behind me is a black drape, and I have glasses, relatively short hair, and gray-brown beard and hair. So I am Forge's co-founder and executive director. We do training and technical assistance with providers across the country. And we also do some direct service work with trans and non-binary survivors and loved ones. We have a really small staff, and we are super excited to be bringing on 2 new people in the next month, and then again in July. So we have some really exciting stuff coming up ahead with new energy in our organization. We have 2 guiding principles, and it's really important for me to always bring this forward about being trauma informed, and that's in the work that we do with trans survivors, as well as with the providers that we work with. And the same is true for being empowerment based. A lot of us think about that when we're working with clients, when we're working with community members, but I also want to make sure that the work that we do with you all as providers, as allies, is also empowerment based. You can find us on social media. We might or might not be moving to TikTok, as well as Facebook, Twitter, Instagram, and YouTube. Let me set up a couple of points of framing to help us kind of solidify where we're starting from today. So why would most therapists be aware of this very unique process of clients coming to seek a letter in order to access medical care? This is a fairly unique to long-time systems that require trans people to get permission in order to access hormones and surgery. It makes sense then that most of the therapists that work in the world would have no idea about trans-related standards of care. Those of you who work with trans clients all the time are well-versed in knowing some of these dynamics that play out. So most therapists don't have a lot of trans clients. Some do. So those therapists that see clients for depression or other life issues may have never heard about or have had the need to consider helping a client access other forms of medical care. Many may not even be able to fathom how informed consent plays a role in trans folks' access of therapy. And, other than thinking about, just basic, does this client give consent to be here and be in therapy with me. So with therapists, many therapists will be kind of puzzled about how this would play any role in clients accessing medical care. It just kind of doesn't make sense for a lot of folks. Like, what does therapy have to do with accessing physical medical care? Some of the older standards of care for working with trans clients required therapists to intervene and approve basically a client before a physician would prescribe hormones. When we talk about things today, about standards of care, either the historical models or the more current informed consent models, what we are mostly talking about is how people access medical care, so hormones and surgery, not much beyond that. Most folks can change their names without the need for a therapist letter. That didn't used to be true. So keep that in mind. The vast majority of trans people seeking therapy do so because of the same reasons that every other person, non-trans and trans, seeks therapy, because they're depressed, because they have anxiety, because they have prior trauma or relationship issues or challenges at work, or dealing with a loved one that has recently died. Any of those common things that people seek therapy for. Although some specifically are wanting to seek a therapist for that access to medical care, it's the majority of folks that are seeking therapy for those basic reasons of depression, anxiety, all of those things. So I'm going to share with you a little bit of the history of trans care. And I know some of the folks that are on the call today are going to be probably bored with this. This is a repeat, but it just helps frame where we're at today. So on the screen is a picture of Harry Benjamin. Harry Benjamin was an early leader, a physician, an advocate, and the drafter of the original standards of care for working with trans clients, specifically working with trans clients who were pursuing medical transition or medical intervention. Many might be familiar with WPATH, so the World Professional Association for Transgender Health. So WPATH was formerly known as HGBDA, and that's in my head from a long time ago because I was part of the world when that was the language. So that would be HGBDA is the Harry Benjamin International Gender Dysphoria Association, and that was founded in 1979. So Harry Benjamin's goal was to protect both providers and trans clients, and to provide a roadmap for providers who were unfamiliar with working with trans clients, which was true for a lot of medical providers at that point in time. The standards of care outlined kind of a timeline, a process, and gave information to help providers and consumers better understand what was going to happen if they started on hormones? What was surgery like? What were some of the things that people needed to know? He was really progressive at his time. He was ahead of his time. And he was also a person who affirmed trans people instead of shunning trans folks from accessing care. It was really common 30, 40 years ago for trans people to have a really difficult time, more difficult than now, accessing care. Note that Harry Benjamin used the word gender dysphoria versus what had been in the Diagnostic and Statistical Manual for a long time, which was gender identity disorder. So again, was he ahead of his time? Yeah, in a lot of ways he was. So many people today, though, look at him and the HGBDA standards or the WPATH standards as really a gatekeeping model. So his intentions were really good. The work that he did was really good, and it laid a framework for us to kind of move into the place where we're at today. So the early standards of care, so we're looking at these WPATH or HGBDA standards of care, required a lot of things from people. It required years of therapy, and that was really prohibitive in a lot of different ways. So it was a cost issue. It was complicated because of the whole diagnosis piece. So if folks had insurance, if the therapist diagnosed that person as having gender identity disorder, which was more true at that time, or gender dysphoria now, the insurance company would often deny access to that mental health care. So that's the kind of the double bind is that versus if the provider does not say that somebody has gender identity disorder, they may not be able to access medical care later on. So there's some catch-22 there with it. But the important part is to realize that Many therapists and many medical providers required folks to be in therapy for multiple years, and that time period has shortened as the standards of care have been revised. The other thing that was a kind of a standard process in these original standards of care was something called the real life test or the real life experience. And this too presumed that people needed to kind of make sure, to really make sure that this was something that they wanted to do, so they wouldn't make a mistake in accessing hormones or surgery. Again, this was intended to be helpful and, under the kind of the do no harm frame of thinking. But this was often very impractical for folks, to live in this binary world of one gender or another gender that's socially kind of prescribed in our culture. It's really hard to do that for some folks without the assistance of hormones, without the assistance of surgery, without the assistance of name change or other pieces that make that real life test more possible. And for some, of course, living in one of these two binary genders wasn't what somebody wanted to do. They didn't identify as male or female. So real life test is kind of meaningless for folks that are non-binary or gender nonconforming. Some of the things that the real life test did, so this was a requirement before people could access hormones and surgery, is it really created some safety issues. So if someone isn't able to live socially within kind of the expected gender roles, it did create a lot of on the streets safety issues. It created some logistical issues. So if someone was supposed to live full time in their new gender at work, but they couldn't yet change their name, that created a lot of kind of chaos and difficulty for that person. And again, it does presume a binary, that people are moving from one gendered box to another gendered box, and that a lot of people don't necessarily want to be in either of those boxes. One of the other requirements of that early standards of care was getting permission. It meant getting approval from a mental health provider before accessing medical care. The standards of care presumed that there would be a very specific outcome after transition. Some of those expected outcomes included people's sexual orientation after transition. Again, so we're talking about people that are going from these one box of male to female or female to male. And the expectation was that people would live in and identify as one of those two binary genders, male or female, post-transition. So if they didn't give room for anything other than those two options. The other outcome that was expected was being straight after transition. So a lot of us today would think, what the heck is that all about? Why would somebody be required to be straight or heterosexual after they transition? And again, it presumes transition, first of all, but then why would they need to have this presumption of straightness afterwards? So many physicians and surgeons wouldn't provide trans-affirming medical care unless people would literally sign documents that say that they were going to be straight after they transitioned. One of the leading gender reassignment surgeons, gender reassignment is the language of his time, Eugene Schrang, who happens to be somebody that used to live in Appleton, Wisconsin, really well-known genital surgeon for male to female folks, for trans women. He would make folks sign a statement if they didn't want to get divorced from their wife. So a lot of times people were in married relationships prior to transition with a wife, and he would require that they get divorced. And if they wouldn't get divorced, that the wife had to sign documents that said, I know that my former partner, husband, now female spouse, is infertile after the surgery, and I'm okay with that. So there was a lot of rigmarole that happened with that. Another example is Lou Sullivan, who's on the right side of the screen. And Lou Sullivan has written a lot of detail about how he was denied transition-related services because he identified as a gay man. The image on the screen, which I know is really hard to read the words on top of it, say, they told me at the gender clinic that I could not live as a gay man, but it looks like I will die as one. And Lou died of AIDS in the early 90s. So why do we have standards of care or informed consent models? One major benefit of any standards of care is that it outlines a bit of detail that may not be readily known by providers who have limited numbers of clients who are trans. In essence, it lays out some common roadmap where both providers and clients get a feel for what some or many clients may do or may get out of specific destinations. A standardized care plan also gives therapists and other providers a feeling of safety and protection from being sued or from clients taking actions against them. Standards of care really don't do this. They don't really offer that that protection against some liability concerns, but it gives that feeling of so providers can think, well, I'm following the rules, which give people that perception of comfort. In recent years, standards of care, specifically WPATH, has become, again, kind of the gold standard for insurance companies who will only cover things like surgery, trans-affirming surgery, if a provider's team, kind of a team of folks, so a primary care provider, a therapist, specifically write letters for that client, that patient, saying that they are ready and appropriate for that kind of medical intervention. So as time has gone on, we've shifted more to an informed consent model. Um, there have been multiple shifts in a lot of different things. So some of it has been a shift in language that was pathologizing. So again, like I mentioned, we moved from gender identity disorder, which was in the Diagnostic and Statistical Manual in version 4 and under. Version 5 of the DSM shifted that language from gender identity disorder to gender dysphoria. So it moved it from something that was disordered, something that was wrong with somebody, to something that made a person feel uncomfortable, not at ease with their body. So this is a better fit for a lot of trans clients, and it's a better fit for a lot of therapists that are working with trans clients. The language, how we talk about gender, has changed, and it will probably continue to evolve and shift both in the DSM and in standards of care. WPATH and other standards of care models have become less rigid over time, both about the timeline. So I mentioned before that people used to have to spend years in therapy. Well, now it's far less that's required in WPATH. It used to be really restrictive about the steps and the order of steps that people went in. The older standards of care didn't mention anything about youth or puberty blockers. It was all expected to be adults and adult hormones or adult surgery. And there's now more inclusion of non-binary identities and the realization that not everybody wants to move from one box to another box. So the language of informed consent is entering into even more previously restrictive WPATH standards of care, as well as being the foundation for many organizations developing their own informed consent policies. Let me scroll on and share with you a couple of the models of care that are fairly common in our world right now. So expanding out from WPATH are many informed consent models of care, including those developed by the University of California, San Francisco Center of Excellence for Transgender Health. It is, in my opinion, one of the kind of the gold standards of sharing with providers many of the things that they need to know about therapy, about hormones, about surgery, about all things medical and mental health trans related. ICAF stands for the Informed Consent Access to Trans Healthcare. It was popular a few years ago, and it's kind of declined in its prevalence. Organizations like Fenway Health out in Boston or Howard Brown in Chicago, they're LGBT health centers. They've both developed their own standards of care that are informed consent based. So they have their process of what that means for them, and that's what they use to provide care to trans folks. And Planned Parenthood across the country has an informed consent model. And it's really beautiful, and it's really, really powerful. So a lot of folks are accessing care at LGBT health centers, as well as Planned Parenthoods across the country if they don't have a primary care provider that they feel comfortable with or knowledgeable, who has the knowledge that they need. When Harry Benjamin was laying out his groundbreaking work, no insurance companies were covering trans-related care. It just wasn't happening. Now, though, many insurance companies do cover trans-related care. And in fact, many folks work at companies like where their diversity and equity and inclusion departments have decided, hey, we really should do something about being inclusive of our trans employees and really work to recruit and gather more trans employees because, hey, why not? Trans employees are great employees. So many companies are really advocating for insurance policies that cover trans-related care, trans-affirming care. And many companies, again, are kind of eager to outreach and let people know, hey, we have affirming healthcare for trans folks. And I know that it's really hard to see the Starbucks cup on the left side of the screen, but what it says as one of the check boxes that are checked, it says inclusive healthcare. So companies are really promoting that as something that's a value added benefit for folks. Someone today who has insurance coverage that includes trans-affirming care, the insurance company may require that providers diagnose their clients with gender dysphoria and may dictate how therapists and physicians need to create that paper documentation trail in order to prove that a client is trans enough for the insurance company to cover the costs. So even when many providers have moved into this informed consent model, insurance companies may be stuck in those models that require that hoop jumping, the gatekeeping, the letter writing. So we talked a little bit about how standards of care worked in the past. We're going to share just a little bit more before we move into some other areas. So traditionally, standards of care would provide a timeline, like we've mentioned, and an order and a process for folks who wanted to receive hormones and surgery. As I mentioned, the early standards of care meant that the process was often really long. And it had a predetermined timeline, or at least a minimum timeline that people had to spend in each of these segments before they could move on to the next step. And it was a really linear process that people were expected to go from one to another, not skip around, not totally remove some steps, but go in a linear order. For example, people needed to be in therapy for a really long time. People needed to do a real life test, sometimes for 1 year, sometimes for 2 years. Really long time before they could even access hormones or name change. Hormones always had to come first before any form of surgery. If folks wanted surgeries, they had to do non-genital surgeries first. And kind of the last piece of the puzzle, the last piece of this timeline was gender-affirming genital surgery. So where do things like real life tests leave non-binary folks? Again, it doesn't leave them anywhere because that doesn't apply to them. When we shift to an informed consent model, it reduces some of those barriers that people have. We also know that some clients may want to, for example, a transmasculine person want to have chest surgery but don't want to use hormones. So folks today, just like folks before, may want to do some different orders of steps and may not want to do a lot of the steps that used to be laid out for folks. It also meant that if folks were not able to get a letter from a therapist, it meant that they couldn't access hormones and they couldn't access surgery. So the question becomes like, who gives consent? So all of this means that a person couldn't give consent to get hormones for themselves. They couldn't consent to that themselves. They had to have consent come from a mental health provider. So this older model of providing care, needed a mental health provider to basically okay medical treatments. And this is totally unlike any other form of healthcare. We don't need to get a letter from a therapist if we have diabetes, or if we have chronic pain that needs to be treated, or if we have routine ongoing physical conditions. Your physician wouldn't imagine asking you to get a letter from a therapist if you had one of those conditions. And many folks, many therapists in particular, can't imagine this model either. So ultimately, like, who did this protect? As I mentioned, the standards of care were developed with the intention of providing both the client and the provider. However, many felt it was really just a kind of a CYA move for the provider. Well, we want to make sure that people do feel protected. Providers feel protected in our very litigious world. We don't want to make it easy for folks to feel, that they're at risk for legal, jeopardy. So who did it protect? We think it's protecting the provider. It's probably not protecting the therapist. And really, a lot of the standards of care were about, let's keep somebody from making a mistake. It presumed that somebody else could help that trans person not make a mistake. And it presumed that doing something, taking hormones, having surgery, transitioning socially, that it could be a mistake. And that even if it was a mistake, that it couldn't be undone. That people couldn't change their mind. So I want to be really, really clear with, in sharing this, that, we didn't and we don't still have a lot of belief that people can make choices. And that choice might be, theirs to make. It should be theirs to make. And they may decide later on that it wasn't the choice that they wanted to make for the long run. And they may decide to detransition. And that is 100% okay. And hopefully folks have the support that they need in their lives. We know that many folks are detransitioning and they're totally happy with their choices. They don't regret the choices that they made. So this presumption that a standards of care would help people to not make a mistake or transition and then want to detransition later is just really false. So a lot of what we're talking about today is really about, are we pathologizing folks? Are we standardizing the process of pathologizing folks? And many trans folks would say yes, that by having a diagnostic code that's gender identity disorder or now gender dysphoria is in essence pathologizing somebody. And it's really easy for trans people to feel this way. There are still these diagnostic codes. There are still these hoops to jump through if someone has insurance and wants to access medical care. Just a reminder that I'm sure all of you on this call know, trans and non-binary identities are not pathologies. Trans people don't need to be fixed. People have autonomy over their identities and their bodies. And we need to, as a culture and a community and a healthcare community, really uplift that autonomy. So let's talk about what informed consent is. Marty Abernathy, who used to be very, very active in writing and in publishing, has this really great quote. She says, informed consent is a medical provider laying out your risks and benefits and the most current information they have about those risks and benefits, and giving you the choice about what to do with your own body. For me, this is a basic human right, a matter of bodily autonomy. So it's a really simple quote, right? It's just saying that people have the right to get in the information and make their own choice about what they want to do with their body. So this model of care acknowledges that the best person to decide if a medical intervention is right for them is the person whose life it is. The photo right now on the screen is one of our former employees, Ashley, who I just love this picture with kind of, pointing at her own t-shirt, but it's pointing at herself. So who should make the decisions about her body? Well, she should make her decision. Everybody should make their own decision about their own body. It's our physician's responsibility to make sure that we're medically okay to make those decisions, just like it would be for any other form of medication or surgery. So practically, what does this mean in practice? So for people who are already connected with a primary care doctor, they may bring up the topic of hormones and pursue it with their primary care provider to see if they'll prescribe. For some people, they may seek specific care, like I mentioned at Fenway Health if you're in Boston, or Howard Brown if you're in Chicago, or some of those places that really specialize in providing medical care for trans folks. Planned Parenthoods across the country, even with a lot of them reducing their hours for abortion-related care, are still offering trans-affirming care at many places across the country. So I want to play for you a video of Riaka Pearl. Let me just stop sharing for a second and reshare to make sure I've got the sound coming through.
I'm going to spend some time talking about the concept of informed consent, specifically as it applies to transgender folks who are looking to medically transition in some way to support their gender identity. I'm not going to spend any time on what those medical interventions might be, but I'm going to talk about informed consent related to the gatekeeper that has historically been behavioral health. So, in the past, when a trans person was ready to have hormones or have some sort of surgery or any kind of medical intervention, a lot of medical professionals would require from that transgender individual a letter from a behavioral health professional. So, generally speaking, in the past, it's been a psychologist, a PhD or a PsyD. More recent, there's master levels clinicians who've been writing those letters. But they really had to see the person for a year or sometimes 2 years and really assess that that person was, for example, if they're a trans man, that that person was male enough to really be appropriate for surgery or appropriate for hormone replacement therapy. Now, that is rightfully, I think, seen as an archaic model. It's paternalistic in the sense of we need somebody to see whether or not you are capable of making these decisions about your own body. Boo, no. So the informed consent model says that people, trans folks in particular in this case, are capable of making their own decisions about their own bodies. Just as if a cisgender woman walked into a plastic surgeon's office and said, "Give me a boob job, I want my boobs to be bigger," the plastic surgeon would be like, "All right." And they would, do whatever they do. That plastic surgeon wouldn't say, "Well, you need to go to therapy for a year and really make sure that you're doing this boob job for the right reasons and not the wrong reasons, and really make sure that you're fully aware of all of the implications," and et cetera, et cetera, et cetera. Right? That cis woman can just go in there and get that boob job, depending on scheduling, I guess. Now, the informed consent model says trans folks at least have as much right to their own bodily autonomy as the person who wants the boob job, right? I also believe that that cisgender woman has the right to bodily autonomy to get a boob job if she wants a boob job. Same thing for trans folks. So basically, if your insurance company requires a letter in order for you to get medical intervention, there are plenty of therapists nowadays who believe in the informed consent model and can meet with you to give you that letter in order for you to make your own decisions. It is absolutely an imperfect system because there shouldn't be a gatekeeper. But while there are, you're looking for folks who are informed consent model clinicians who believe in your ability to choose, basically, in a nutshell. If you have any questions about gender therapy or anything else that Rika does, go ahead and email me at rikapearl@gmail.com or find me on my website at www.rikapearl.com. Until next time.
And I apologize for not warning folks that there was some slang language in there. So when we look at autonomy, the prior video really talked about autonomy. The process of permission by a mental health provider really reinforces a system of power imbalance, and it totally strips the person of their own bodily autonomy in making the best choices for themselves about their body and their life. So Ruben Hopwood, who used to be at Fenway Health and is now in private practice, he's a really well-published author and a really, really snappy dresser and a really cool dude. He wrote in an article a few years ago that for trans people, informed consent represents autonomy and a departure from stigma, allowing patients to make their own choices about their bodies. The individual nature of this model allows care providers and patients to tailor it to individual needs. And that's really, I think, what a lot of us want to do. When we work with clients, we want to tailor what we're doing with them to their needs. So many people look at this power imbalance as a dynamic that's rooted in the hierarchies of oppression or privilege, where one group of people automatically has more power than another group. This practice of removing bodily autonomy is also entrenched in stigma around bodies and the mainstream belief that some bodies are less than other bodies, or that some people and their bodies need to be legislated and controlled by others. In many ways, the lack of understanding of trans identities and experiences has been controlled by the people who can't really imagine being trans. They look at trans people as the other and unusual, and like the actions of a trans person might take are radical and in need of being controlled and legislated. And a lot of that is really the root of some of our current cultural issues, which we're going to talk about in a few minutes. But that power imbalance really gets heightened for a lot of trans people and their providers. In addition to taking away bodily autonomy, the process requiring people to spend hours and hours in therapy just for a letter was really cost prohibitive, as I mentioned before. Not only did someone else hold the power over their body, many people couldn't even afford to jump through this really power-laden set of hoops. For decades and even today, many trans people don't have insurance. So until fairly recently, trans-related care wasn't covered by insurance. And for those who had it, it was oftentimes denied. Gender identity disorder, as I mentioned before, was oftentimes excluded, which meant that therapy wouldn't be covered as well. And this is changing again as we've moved from gender identity disorder to gender dysphoria. So this oftentimes led people to not being able to get other services covered as well. So couldn't access therapy, couldn't access medical services. So a reminder that informed consent and standards of care models, either way you want to look at them, either the older school or the newer school, only matter when someone wants to take specific actions related to their transness, specifically hormones or surgery, or something maybe like legally changing their name if they're in a state that requires letters. Otherwise, informed consent models, standards of care, don't play a role in providing mental health care. So they only play this role in this very limited way, in this limited time, and that's it. So to be a little bit more detailed, informed consent and standards of care models are really only relevant when working with a trans or non-binary person for that very short period of time in their lives and for a very specific purpose. So when they want to get surgery, when they want to have hormones, use hormones, when they want to have a name change. The vast majority of the time that somebody is going to be spending in therapy is going to be on those same reasons that you see all other clients for depression, for anxiety, for all of those things that we've talked about already. And the letter writing is only that one little thing, that one little piece that may or may not happen. So I want to talk for a minute about clinician boundaries and parameters. So for a lot of folks, letter writing seems like this weird thing, like they don't do it for other clients. Why would they be doing it for trans clients? So, this is something unique that trans clients are going to be asking of their provider if they want to access hormones or surgery and if that medical provider requires it. Therapists, of course, need to decide if they want to have a practice that includes providing traditional therapy, what's their bread and butter, or if they would also like to do things like write letters for their trans clients, if that's needed by the client. And it's obviously okay for a provider to make their own determination about what they're comfortable with, and we all feel comfortable at different things, but to know that ahead of time and to be clear with clients about, yes, I'm willing to write letters, or no, I'm not, and have that be one of those first conversations so that everybody knows everything up front. So if a provider is willing to write letters, what parameters do they set for this work? Do they set any parameters? I'm sure they do. Everybody does. So do they only do so for clients who are in long-term therapeutic relationships with them? Will they write a letter for someone who comes specifically for a letter and not for longer-term therapy? So they might be only there for one session or two sessions. Will a letter get written for those clients? Do therapists require people to come for a specific number of sessions before writing a letter? So some therapists do one session and will write a letter. Some may require folks to be there for multiple sessions. And again, that kind of strays between the informed consent and the more restrictive models. Does the client need to prove or provide anything before the therapist will write a letter? So do they need to show that they've come out to their partner, or that they're in the process of a legal name change, or do they need to prove anything? And I use that in quotes, but that sometimes is one of the parameters. Is there transparency in the letter writing? So does the client get to see and participate in that process? Or is there a hierarchy kind of up in that process that the therapist writes the letter, seals the letter, and mails it to the physician? But does that client get to see and participate in that? Do they both get to decide what diagnostic codes are included, or what kinds of personal history or data are included in the letter? So for example, how can the letter meet the needs of the medical provider or the insurance company, but also respect the privacy or the request from the client? Any decision about writing letters or not writing letters is, of course, totally fine. Again, I mean, that's a choice that every provider can make. And clients just need to know that up front so that they don't have to spend a lot of time and money investing in something that may not end up with an outcome that is desirable. So some providers who are willing to write letters will do so in ways that so clients can access affirming care. And they might have some exceptions where they feel uncomfortable in providing a letter. So again, this may kind of bridge that gap between the older standards of care and an informed consent model. So some examples where providers may not feel comfortable writing letters is, for folks that are actively using substances or actively self-harming. Those are common things that a lot of therapists feel uncomfortable writing letters for that person if they're actively using or actively self-harming. Other therapists are totally fine with that and acknowledge some of those harm reduction principles that go with those behaviors. Some won't write a letter if someone is living with a dissociative condition or other serious mental health condition. Some may abstain from writing a letter if they feel that their client hasn't thought through the implications of their actions or isn't informed enough to make those decisions. Again, totally fine to have those boundaries to do what's ethically comfortable for that provider. The key really is to share that information and to be transparent about it with the client. So one of the examples that I like to offer is that sometimes when people go into therapy and they're dealing with really severe depression, and they might have suicidal thoughts or feelings, or maybe even have had some suicidal action in the past. A lot of clients want to know how that provider is going to respond. So this is not about transit. This is just about suicidal depression. And the client wants to know, hey, is my provider going to call 911 on me? Are they going to try to institutionalize me if I say that I'm suicidal? Or will they work on creating a safety plan with me? Will they work on helping me be okay enough to stay alive in this moment without calling 911, without putting me at additional greater risk? So that's an example that I like to use about, having that discussion ahead of time. And it's just like having the discussion about letter writing. So what is the provider willing and able to do? How will it play out? And is that going to be comfortable for both the provider and the client? Again, I mentioned harm reduction, and that's it's a catch-all phrase, but, when we look at older standards of care, alcohol, drug use, non-suicidal self-injury, lots of those kinds of things used to be a make or break point for folks accessing additional gender affirming care. So I encourage all of us to think about what harm reduction is. If those clients who are using alcohol or drugs, for example, if they're doing so as a coping strategy because the world is so difficult to be in as a trans person, or if they're self-harming because it's the only way that they know to get out the pain that they're feeling. As therapists, a lot of you know what the deal is with all of that. But, if we have that lens, will we feel more permissive, if you will, in helping clients get to where they need to go, even if they're doing some behaviors right now that may not be in their best long-term health? So let's talk a little bit about what things are like in today's world. So, although the majority of anti-trans bills are related to medical care right now, I mean, they're related to sports access, they're related to bathrooms, they're related to accessing medical care, they're related to drag events. Providers, mental health providers, maybe wanting to pay attention to what's going on in the legislative action. So I'd like to share with you 4 examples of how different states are criminalizing or harming providers who care for trans and non-binary clients. And these are things that are going to maybe cause some moment of pause for people, both clients and providers. And we don't know where this is going to go. And that's kind of a scary place to be. So in Texas, there's a Senate Bill 1029, which makes health insurance plans strictly liable for all claimed gender-affirming care damages for life. So let me read that again. So this bill makes health insurance plans strictly liable for all claimed gender-affirming care damages for life. It also makes doctors offering gender-affirming care liable for malpractice. So in this, it says doctors, it says insurance plans, and there's a slippery slope about where other types of providers come into the equation here. Florida. So we've got Texas, which is kind of a hotbed for legislative action. Florida, which is another one. And I can't believe that this act is actually called the Reverse Woke Act, but it is. This would make employers liable for the entire life of an employee that received gender-affirming care throughout their employment and insurance if they decided to detransition. So again, it's really putting a lot of weight and pressure on an employer, and that employer may decide that they don't want to have trans-inclusive care because of the liability risks. So again, just lots of pressure being placed on the providers, the insurance companies, the employers. So South Dakota just signed into law HB 1080, and it passed pretty not unanimously, but very heavily. It passed, and it outlaws prescription and administration of puberty blocking medications in patients under the age of 18. Healthcare providers who violate this law will risk civil suits and losing their professional or occupational licenses. So this one is pretty clear that it extends outward from just physicians, nurse practitioners, physician's assistants to a broader healthcare network. And the 4th example is the SAFE Act, which is Save Adolescents from Experimentation Act. And it became law in Arkansas after the General Assembly overrode the governor's veto. The SAFE Act prohibits health insurers from covering the cost of gender-affirming healthcare. Next, it sets up a process by which healthcare professionals who offer gender-affirming care will lose their license to practice medicine. It also issues a blanket ban on the provision of gender-affirming healthcare. So again, these are 4 states that are really radically taking positions which are incredibly harmful for providers and incredibly damaging for trans consumers, trans youth, trans adults. And I added this here not to make us all scared, but I think it's really important for us to know what's going on, to be aware of what's going on in our states. These are not the only 4 states that are doing things like this. Many, many, many states across the country are. In addition to those legislative efforts, clients might have a lot of fears about, if you're a gender therapist and see a lot of trans clients, will they be fearful about walking into your office because maybe somebody else will see them and they'll be outed? Are they concerned about if their employer is going to know? So a couple of those bills kind of remind folks that their employer might know if they're seeking care around gender issues. Their insurance company would certainly know if a provider uses one of those diagnostic codes that discloses their gender identity. And all of that can bring about just major feelings of safety risk, safety concerns that may stop clients from pursuing any form of gender-affirming care. So let's talk for a moment about how all of this, so the standards of care, the legislation, how it can impact the therapeutic relationship. So again, both those current cultural issues and the pervasiveness of the continued standards of care, even when providers are using informed consent models. These are things that contribute to, how clients work together with their providers. So for clients who are seeking mental health care services that are part of or all of the process to get a letter for hormones or surgery, clients might intentionally choose to not disclose specific things about their life. So clients might know that some pieces of their life might kind of, perk up the ears of their therapist, and the therapist might not write a letter. So some of those things, like I mentioned before, where therapists may want to think about are if a client is actively using drugs or alcohol, they may think, I better not say anything about that because that may impact my ability to get on hormones. Or I'm not going to mention, like the photo on the screen, that I have previously engaged in cutting or non-suicidal self-injury in the past or in the present. I'm not going to talk about the abuse that I experienced as a child because people are going to think that I'm not really trans. I'm just dealing with abuse issues and I need to work on that instead of being trans. People may not disclose things like that they were bullied as children or have life experiences that are really discriminatory. They may not want to disclose that they work in the underground economy as doing sex work or using, selling access to other forms of substances that might not be legal in this country, or anything else that they think that a therapist might hold against them or not allow access to affirming care. So because of some of these concerns, we are continuing over and over and over again, to see that many trans clients are seeing two therapists. They're seeing one therapist to do their gender-based work. So to get a letter, if they need a letter, to talk about their gender, to talk about what's going on for their gender, if they need support for that, which a lot of folks do, a lot of folks don't. And then they're seeing an additional therapist, another therapist, or at another point in time to talk about the rest of their life. So their depression, their anxiety, their post-traumatic stress, and they may not talk about their gender with that therapist. So there's this divide, and it can really do some damage to both the trust in therapeutic relationships, as well as that person's wholeness and being able to heal from some of the challenges that are happening in their life. So the gatekeeping model and the need for formalized standards of care that is imposed by some of those companies, insurance companies, and some medical providers creates some really tense therapeutic dynamics that can lead clients to feel that they need to perform, they need to act in a certain way, to maybe be cheerful, to be happy, to be some of those things that make providers think, oh, I'm going to give this person a letter. It may contribute to a lack of openness or a lack of trust. It might create a transactional relationship. I'm going to do this for you. You're going to do it for me. We're good. And that transactional relationship could be, I'm paying you as a trans person, I'm paying this provider and you're going to supply me with a letter. And that's what we're doing. It might be creating a relationship that's based on literally paying for a ticket to trans affirming healthcare. All of these things create, greater power imbalance than already exist in a therapeutic relationship. So what can we do to build stronger therapeutic relationships? And, I'm not going to tell the folks here that are providers how to do this, because you all know how to build strong relationships with your clients. And this is just another one of those things where the trans pieces of things may be impacting that strong therapeutic relationship. So pulling those tools from your toolbox about how to create those strong relationships is going to be really essential for folks who might be coming in with a little bit less trust or a little bit of concerns about how that relationship is going to go. A couple of reminders about trans-specific informed consent, standards of care related issues that might be important in maintaining that strong therapeutic relationship are to be really clear about if you're willing to write a letter for a client, if they're willing, if you're willing to affirm and support their ability to make their own choice medically on their gender journey. Have a clear contract with your client. And this could be a written contract as well as, a verbal contract about if you have any strings that are attached to therapeutic process or any requests that trans folks might have to have you support them in their accessing medical or legal care. Overtly ask clients if they're there for a letter. or if they have other life issues that they want to work on and focus on, or if it's both. So those are just some reminders that, I'm sure all of you have thought about and do regularly with the clients that you work with. All right, let's do the phone thing again. If folks can get out your phone, I'd like you to think about how you can affirm your client's autonomy. So how can you affirm or empower your client's autonomy? And let me start the poll. And hopefully folks will be able to see the poll and enter it. And if you can't, feel free to type in the chat. So how do you affirm your client's autonomy? How do you boost them up, lift them up, let them know that their body is theirs and theirs to make their own choices about? So someone's writing, I involved them in the process of, I involved them in the letter writing process. We edit together. Excellent. Really great to hear. What other things do folks do to affirm somebody's autonomy? Always have my clients edit their letters from me. Excellent. Yeah. So that folks know what's in those letters and make sure that there's only information there that clients want to have there, the information that they want to share with another person. Excellent. Those are great examples. Thank you for sharing those. So of course we can put that autonomy into action a lot. I'm going to share with you a video from Planned Parenthood of Metro Washington, D.C. And again, Planned Parenthoods are really fantastic about providing gender affirming hormones and providing all of that care through an informed consent model. So this is a really beautiful video, as well as just kind of a summary of what we've talked about today and a little bit more about why informed consent models of care are really essential.
People within our community that avoid appointments, avoid going into the doctor because they don't feel seen. They're afraid of being misgendered. They're tired of being misgendered and not being seen as they truly are. And having access that takes into account their identity, their needs as an individual and not just, as a subset is really important, because it helps people to get the care they need to be their best person. It is so important for trans people to have informed consent as it comes to hormones, because it gives that individual complete autonomy over their own body and what they want to look like, how they want to present. And it's important because it also gives individuals the ability to choose how much of a hormone they want to take, and that allows them to kind of find a version of themselves in their body where they feel comfortable, where they feel like their complete self. And that's why informed consent is so important, because the decisions that we make need to be about us and our needs instead about someone else and what they perceive of us.
So I hope folks were able to see the beautiful people that were in that video, and even the things like moving around the set while they were doing the photo shoot and filming it at the same time. There were lots of things that were in that video that I think are really, really, really neat, and talked about things that remind me of some of the other components of older standards of care that now are becoming more obsolete, like people choosing to take smaller doses of hormones, or going on hormones and going off hormones, and really doing what feels best in their bodies and working with medical providers to get to that point. So let's talk a little bit about actions. Let's figure out some things that we can all do. And again, I know that a lot of you are doing all of these things when you work with clients, but again, being clear with your clients about what you will, what you won't do on their gender journeys. Working with your clients to affirm their goals and the path that they're on. Knowing who the providers are in your area or in your community, who prescribes hormones, who operates under informed consent models. Ideally, it's also, good to know which providers use different types of care, and who their colleagues are and who their colleagues are, so that, clients can get connected to people that are in line with what they need and how they want to live their life. And use medication or surgery in ways that affirm their identity. It's also important, I think, for mental health providers to know where affirming support groups are if a client wants or needs them. Not everybody wants or needs to get connected with other trans folks or other different types of support groups, but it's important for therapists to know that so that people can get connected. And again, that's another way to empower clients. It's another way to bring in that informed consent model of like, this is what this client might need, and let's figure out how we can help them reach those goals and get what they need. The last simple thing here is to share with colleagues about informed consent models. A lot of people may not have, any idea what working with a trans client is about, other than they're trans, and they might have these common issues that other people experience around their mental health. But share with them what it means to help support that trans person be able to access other types of gender affirming care. We have about 15 minutes left, and I'm really sorry again for all of the technical challenges that we've had today. It's been a day. So if folks have comments or questions, now is a really great time for them. I'm going to put up the next slide, which has my contact information. Our website is on all of the slides as we've gone along today. Do folks have comments? I've seen some great things in the chat. And, someone is writing about autonomy, never assuming what my client wants, who they are, or where they want to go. Exactly. Yeah. And I think, in addition to that, and I know this person who made the comment, it's like, sometimes where people want to go one day is a little bit different than where they want to go the next day. And always having that conversation and always making an environment that's open for people to say, you know what, I'm thinking about this differently now. Can we go in a different direction? And that might mean talking about it. It might mean medically going in a different direction, but always having that openness to have those conversations. Are there other comments that people would like to make? Other questions that people would like to have? So I'm seeing a comment that says, I have many trans clients who are in fear about these laws. Any comments on how to support them? That is really a good question. We just did a webinar on state-sanctioned hate, and I know that that's not going to necessarily get folks to how to support them. I don't think a lot of us have the answers. And one of the things that Forge is really excited about, and I'm not trying to be self-centered in sharing what I'm going to share next, but we have funding through 2 federal agencies to work on hate-motivated crimes and state-sanctioned hate. So some of the laws that are coming down, and we are hoping to develop some of those strategies because it's really uncharted territory. So I'm hoping that we're going to get there. And I would really love, many of you today that are on this webinar have really great experiences in figuring out how to help your clients not be so paralyzed by what's happening. So I would love other folks to pipe in with their thoughts about that. And I'm seeing that, folks are seeing increased anxiety and depression in their clients. And probably in themselves as well, because it's hard to be in this world without feeling the weight of those really, really, really painful and dehumanizing laws that are getting passed. Yeah, so we are using state-sanctioned hate a lot because we believe that that's really what it is, and it's horrific. Yeah. Any other questions or comments before we close out today? I want to thank Caleb and Laurie for being the ever strong back end today, and our 2 ASL people who jumped in last minute. So I'm really grateful for both of them, especially on the West Coast. One is in Hawaii, like I mentioned at the beginning. So it's really, really early in the morning there. And we really appreciate both of their excellent interpreting. So thank you very much. Hope that you all have a really great rest of your day. And please take a minute if you can to respond to the evaluation survey. Thanks, everybody.